we are going to discuss on the practical part of the resuscitation today. The room temperature of the labor room or OT should be 26 to 28 degree centigrade. And we have to switch on the radiant warmer 30 minutes prior to the delivery in manual mode. We have to keep ready oxygen cylinder at 5 to 10 liter per minute, and the suction pressure of the machine sucker should be 80 to 100 millimeter of mercury. And if we don't have the radiant warmer, we can use a 200 watt bulb, keeping it 50 to 60 centimeter above the delivery surface. So after preparing the room, we go for 6 steps hand washing, and then we check the small instruments. So we need 2 sterile towels under radiant warmer to make it pre-warm towel. Then a shoulder roll up to 1 inch in diameter. Then sucker. Sucker may be 4 types. Bulb sucker, Dilly's mucus sucker or manual mucus extractor, then slow machine sucker and central sucker. Now bulb sucker is obsolete now because it is difficult to clean and chances of cross infection is high. So nowadays we use this Dilly's mucus sucker. It has a chamber and 2 tubes. The green end goes to resuscitator mouth and the other end in baby's mouth. So first we put the baby's end in baby's mouth. Then we create a negative pressure and take out the tube in negative pressure. And the minimum volume of this chamber should be 20 ml. Because if it is less than that, then the fluid can be regurgitated in resuscitator mouth. So this is the sucker. Now the most important instrument, this is self-inflating bag with valves. It is also called AMBU bag, artificial manual breathing unit, but this is a misnomer. Now it is a siliconized bag, size 2, 250 ml for preterm baby and 500 ml for term baby. The face mask may be also of 2 sizes. 0 for preterm baby and 1 for term baby. This is 1. 0 for preterm and 1 for term baby. Shape may be also 2 types, circular and anatomical. The circular one is preferred because it gives proper seal. Now AMBU bag has 4 valves. At the back it has inlet valve. So when we press the bag, the inlet valve closes, and when we release the bag, the inlet valve opens and allows the air to enter inside the bag. Second valve is safety valve or pop-off valve. It releases extra pressure from the bag. Third valve is inspiratory valve or fish mouth valve. It allows oxygen to go inside the baby's mouth, and the exhaled air from baby goes to the environment through the expiratory valve. This is at the periphery. So this is the 4 valve of the bag. Now on the back of the AMBU bag there is 2 inlet. The small one is the oxygen inlet. We attach the oxygen tube here, and the large one is the air inlet. We attach the oxygen reservoir here. The oxygen reservoir may be 2 types, closed type or open type. Open type may be a corrugated rubber tube with open end. Now, this is an empty bag. How it is filled up with oxygen? So, when we press the bag and the inlet valve is closed, then oxygen from oxygen tube goes to the reservoir bag, and thus after few compression, the bag will be filled up with oxygen. Now, when we don't attach any of the tube, it will give 21% oxygen of air. When we only attach the oxygen tube here, it will give 40% oxygen. And when we attach oxygen tube and oxygen reservoir both, then it will give 90 to 100% oxygen. Now the question is why we gradually increase the oxygen concentration? Because oxygen may cause toxicity to newborn baby like retinopathy of prematurity and bronchopulmonary dysplasia. Now before using this bag, we have to check the bag whether properly working or not. For that purpose, we have to check the air pressure. Then we have to check the safety valve working or not. We close the outer end of the bag and there will be a hissing sound from the safety valve or pop-up valve. And we have to check the recoil of the bag. This is the hissing sound of the safety valve or pop-off valve. Now, what is the advantage of this bag? Advantage is self-inflating property. That means without external air source, the bag inflates itself. And what is the disadvantage? Disadvantage is it cannot give free flow of oxygen. And the contraindication is we cannot use in congenital diaphragmatic hernia. And how we clean it? If it is soiled with blood, we have to first clean it with detergent. Then we put it in 2% glutaraldehyde for 20 to 30 minutes for decontamination and 6 to 8 hours for sterilization. And after this, we wash it with distilled water, air dry and cover it with autoclave piece of cloth. And if we want to autoclave, we can autoclave the siliconized part. Third important instrument is endotracheal tube. It is of uniform diameter and uncuffed. Parts are adapter, the tube and the vocal cord guide. And size is 2.5 to 4 millimeter internal diameter. And along with this, we need a laryngoscope and the blade size will be 0 and 1 and it will be straight blade. So this is the instrument. Now when a baby delivers, we have to ask whether the baby is breathing or crying, term or preterm, and muscle tone good or not. Now the most important single question is whether the baby is breathing or crying. And gasping breathing is also considered as the no breathing. Now we immediately receive the baby in pre-warm towel and put the baby under the radiant warmer. We position the baby with shoulder roll under the shoulder blade to slightly extend the neck. This is called sniffing position. To bring the airway in a straight line. Then we have to suction. First we suction the mouth, then nose. Because the newborn babies are obligatory nasal breather. If we suction the nose first, then the secretions in the mouth will be aspirated if the baby starts breathing. And we can go up to 5 centimeter inside the mouth and 2 centimeter inside the nose. Because if we go beyond that, then it will touch the posterior pharyngeal wall and it may cause apnea and bradycardia more. and the suction pressure will be 80 to 100 millimeter of mercury. Because we give more pressure, then it will cause esophageal mucosa to slough out, and that will cause postnatal esophagitis and vomiting. And this duration of suction is 15 seconds. After suctioning, we have to dry the baby, first head and face, then axilla and hands and body, then legs and groin. Head is first because head is the largest surface area in a newborn baby. Then we discard the wet towel and take another pre-warm towel. Then we give stimulus to the baby, flickering on the sole, slapping on the sole, or rubbing on the back. And then we reposition the baby in for the next step. This sixth step is called initial steps of resuscitation, and it takes 30 seconds. Next, we have to evaluate the baby, whether the baby is spontaneously breathing or not, and heart rate more than 100 or not. For heart rate count, we have to count for 6 seconds and then we multiply with 10. We can check the umbilical cord pulsation or precordial auscultation for heart rate, and precordial auscultation is better. So after this, if the nowadays we use 3-lead ECG for monitoring the baby. Now after this, if the baby is spontaneously breathing and heart rate more than 100, we send the baby for routine care. If heart rate less than 100 or the baby is not taking spontaneous breathing, then we go for the next step, that is positive pressure ventilation. And if the baby is breathing and heart rate more than 100, but baby has labored breathing or cyanosis, then we have to give CPAP. Now, where CPAP is not available, then we again suction the baby. Then we give free flow oxygen, 100% oxygen from oxygen tube, and we monitor with pulse oximeter. Now there is another question. If the baby has meconium stained liquor and baby is non-vigorous, that means baby is not breathing, heart rate less than 100 and muscle tone is poor, then we have to do first intertracheal suctioning of the meconium. We do it 5 to 6 times, or earlier we can stop if there is further bradycardia, and then we do the initial steps of resuscitation. Now positive pressure ventilation. What is the indication of positive pressure ventilation? No spontaneous breathing and heart rate less than 100 after 30 seconds of initial steps of resuscitation. Now baby in sniffing position, resuscitator at head end or by the side of the baby to get an unobstructed view of chest wall. Now face mask should cover tip of the chin, mouth and nose, and it should not cover the eyes. We attach the mask with thumb and screwing movement and hold the mask in EC clamp, that is index and thumb makes the C and rest of the finger E. After holding this, the 3 fingers will move the chin forward and then we give it the downward pressure, but not much pressure that it will cause bruise. So this is the holding of the ambu bag. After that, we start the positive pressure ventilation. The initial pressure will be very high because the fetal lungs are fluid filled. For term baby, it is 30 to 40 centimeter of water, and for preterm baby, it is 20 to 25 centimeter of water pressure. And gradually, we decrease the pressure. Now, rate is 40 to 60 breaths per minute because it is the normal respiratory rate for a newborn baby. And rhythm is breath 2, 3, breath 2, 3. Now during breath we compress, and during 2 and 3 the bag will release. Now why the release part is more than the breath part? Because physiologically expiration is prolonged than the inspiration. Now doing AMBO bag we have to check the chest movement. Chest movement should be gentle. If the chest movement is very high, then we have to decrease the pressure, and if the chest movement is inadequate, then we have to do ventilatory corrective measures. What are those? These are reapply the face mask, reposition the baby, suctioning, slightly open mouth, increase pressure, and endotracheal intubation. Now each time we do 2 methods and then we again recheck whether the chest wall movement is adequate or not. And nowadays we monitor in pulse oximeter, and pulse oximeter probe should be attached in right upper limb because it is in preductal position. Now we do the AMBO bag for or positive pressure ventilation for 30 seconds, but we may have to do it repeatedly, and if we have to do it for more than 2 minutes, then we put a 6-fringe orogastric tube through the mouth, and it has open end to decompress the stomach, because stomach will press the diaphragm and it will compress the lungs. Now after 30 seconds of AMBO bag, we have to again re-evaluate. If no spontaneous breathing and heart rate less than 60, we have to do chest compression. If heart rate between 60 to 100, then we do only positive pressure ventilation. And if the baby is breathing and heart rate more than 100, we gradually slow down the AMBO bag, and then we send the baby in post-resuscitation care. In post-resuscitation care, we have to monitor the baby respiratory rate, heart rate, temperature, color, and blood glucose. Now another question, what is first golden minute? It is the initial steps of resuscitation, evaluation, and initiation of positive pressure ventilation. And this is the most important 1 minute, because we can survive most of the baby during this 1 minute. Now what is the indication of chest compression? No spontaneous breathing and heart rate less than 60 after 30 seconds of effective positive pressure ventilation. Now component 2, compression and release. 2 resuscitators are needed, and the method again 2, thumb technique and 2-finger technique. Which is preferred one? Thumb technique is preferred one because it gives better control on the depth of the sternum. So first the baby on the firm surface and in sniffing position, and we have to give 100% oxygen through positive pressure ventilation. Now we look at the position where we give the chest compression. It is the lower part of the sternum, just above the G-sternum. So we go through the subcostal margin, look at the G-sternum, and just above that. Now in thumb technique, our distal phalanx will be vertical, because if we give lateral pressure, then the area of the pressure will increase and then the effective pressure will decrease. And there must be gap between our hand and baby's body, because the chest wall of the baby will be expanded. Now the depth of the compression. Depth is 1/3 of the anteroposterior diameter of the chest wall. If possible, the second person can intermittently check the femoral or carotid pulse to check the effectiveness of chest compression. And in between compression, we should not lift our fingers, because if we lift our fingers, then it will be difficult to relocate again, and chances of fracture of diphisternum is high, and it will cause liver laceration. And this is the 2-finger technique. Now in 1 minute we have to give 30 breath and 90 chest compression. And the rhythm will be 1 and 2 and 3 and breath in. 1 and 2 and 3 and breath in. 1 compression and release. 2 compression and release. 3 compression and release. Breath, compression of the ambu bag, and release of the ambu bag. And we do it for 30 seconds again. Now, why the chest compression is 90, whereas the baby's heart rate is 120 to 160? Because manually we cannot give more compression. Now, after 30 seconds, again we evaluate in same manner, and if the heart rate is still less than 60, along with chest compression and positive pressure ventilation, we can give injection adrenaline. Adrenaline is available is 1:1000. We make it 1:10,000, and then we give it 0.1 ml IV through umbilical vein. So up to this is the practical part.